Good afternoon, everyone. We're just going to give it another minute or so to start and let people come into the room. All right. Good afternoon and welcome. I'm Josh Miller, a project manager with the Rural Health Redesign Center, and I'm here with my colleague, Tom Harlow, project director. Thank you for joining us today for part two of our webinar series focusing on workplace violence. A few housekeeping items before we begin. We encourage you to submit any questions in the designated Q&A section. We will do our best to address them during the session. And any remaining questions will be answered when we release the session recordings. Today, we'll address a critical issue in healthcare, ensuring a safe, supportive environment by effectively identifying risks and implementing proactive strategies. This session is crafted to equip healthcare professionals with the tools to recognize key risks and warning signs, adopt best practices in prevention, and develop strong crisis response plans to protect staff and reduce workplace violence. I have the pleasure of once again introducing Brendan Riley, an expert in healthcare security and violence prevention. He has over 2 decades of experience and has led security, emergency preparedness, and workplace violence prevention programs across multiple healthcare institutions. He is a certified healthcare protection administrator, a recognized industry leader, and an advocate for improving workplace safety in healthcare settings. And with that, I'll turn it over to Brendan.
Thank you so much, Josh, and thank you again to the Rural Health Redesign Center for inviting me back. It's really my pleasure to be here in front of this audience for part two. Today's session is called Workplace Violence Prevention, focusing on what's most important. And when it comes to protecting our caregivers and our patients and our healthcare facilities, everything's important, but there are some things from my vantage point that are more important than others. We have to prioritize somewhere. And if I'm to give a knock on healthcare from my experience over the years, is sometimes we feel so overwhelmed by the weight of everything that we're responsible for, and understandably so, that there's so much to get done that nothing gets done. So I'm really on a mission to help folks really prioritize in a sensible, pragmatic fashion of what is most important to do right now to prevent violence and to protect our workforce. So that's what I hope to discuss with you today. And a couple of objectives here. I want everyone on today's webinar to go back and reflect on what I talk about with your colleagues and your leaders with some new perspective. And your foundations for your violence prevention program might be different than mine, and that's fine. But determine what you stand for and what you are going to prioritize as we move forward here, and then try to impact that change on your organization here. I mean this, I believe that healthcare is the most noble profession. I've been doing this for 25 years, and this is especially true of rural healthcare. Full disclosure, I'm city folk. I work in an academic medical center, 400 hospital beds, but through my work with International Association for Healthcare Security and Safety, the past 2+ years, I've really made a lot of connections with rural healthcare and critical access hospital folks, and it's been really inspiring to me. I've learned a lot, but your healthcare at its purest form. You take care of your communities, and you do so in a manner that is so under-resourced that it is unimaginable to a lot of folks who sit in academic medical centers like myself. So I have a genuine appreciation for what you do, and you keep showing up, even though we've been through so much the last few years. So our core values as caregivers are really that empathy, that compassion, those great communication skills, that knowledge, that teamwork that certainly is ever present in the rural setting are really what make us great, what make us so noble, and this is what we try to live up to. And I really think the values of a great caregiver are also the same values of the safe caregiver, and that was a big emphasis for the part one webinar, which was focusing on safely managing agitation and aggression. I welcome anyone that hasn't viewed that to go back and view that webinar on your own time. Um, and this is my hypothesis here. I am convinced that the overwhelming majority of healthcare workplace violence related injuries that are physical in nature are entirely preventable. And this is really where I stand with my organization. When I came in here, we had dozens upon dozens upon dozens of bedside caregivers battered at the bedside and out on injury year over year over year. I'm very proud to share that the last fiscal year, we had zero people in a workforce of 6,000 that lost time because of a physical injury of workplace violence. We had one colleague lose work time because of emotional trauma, which is just as important, but we did not have one physical injury from an act of violence prevent somebody from coming in and doing their work here. So really, to me, the current state of things, and I'm not trying to be overly critical here, but I am going to share my opinion and my perspective. Data drives all of our decisions in healthcare, but not necessarily when it comes to workplace violence prevention. And there's a lot of misplaced priorities and investing in some of the larger academic medical centers when it comes to violence that are not data driven whatsoever. The cool thing about rural healthcare is you can't afford to make bad decisions and mistakes because you'll have to shutter your doors. So you have to be incredibly thoughtful about your priorities, and I'm sure your data is driving your decisions, and it should. This is from the IHSS Foundation, the annual crime survey. So you could be a 1,000-bed hospital or a 10-bed hospital. You report into this survey, it goes into an aggregate, and then we just measure assaults and injuries per 100 hospital beds in that data set. And you can see from the bar chart there, year over year, we're seeing drastic increase on this assaults on caregivers. And the four types of violence, type one is criminal intent, type two is patient generated, type three is lateral violence, type four is outside relationship. Entering the workplace, we can see 93% of that pie was patient-generated reactionary violence, often occurring right at the bedside. So much of what's going on that's harming caregivers is that, but that's not necessarily what we've been focused on the past few years, or heck, a decade now, which has been hyper focused on active shooter and weapons detection from my perspective. And I'm not minimizing the importance of having a plan for extreme violence. But really, I think priority number one needs to be protecting those bedside caregivers from battery that can cause considerable type of harm. Every organization I network with is seeing a trend line like this year over year over year. The volume and the severity of violence increases, but from my perspective, 25 years, we're doing the same interventions that we've done for decades. And I think it's time for healthcare to step back and kind of just take a harder look at what we're doing now and kind of move on to new priorities based on those data trend lines that so many organizations, and certainly nationally and globally, that we've been seeing. Last session, I talked a lot about the current state of things. I think we united all see people at their absolute worst. Unless you're delivering a baby, for a family, nobody wants to be in the hospital. So we see people that are emotionally charged during the times they're with us. They're under stress, they're fearful, they're really at the worst. They might be living through the worst moments of their life. Everybody's had a bad past experience. Everybody on this call, whether your own care or a family member's care. And those are the root of all conflict, bad past experiences and especially unmet expectations. Our patients and their family members expect perfect free and now. We can't deliver that. So we're going to see people that are emotionally charged. We focused an awful lot on caregiver burnout over the course of the pandemic response and thereafter, but there's such thing as patient burnout. And this really scares me that our patients are paying more than they ever have for what they perceive to be lower quality of care. At the very least, it's much more difficult to access care now than it was even a generation ago. And we're seeing a lot of this resentment towards us, those who are working in hospitals, the hospital institutions themselves, and the providers. And that feels really new to me. Resentment towards healthcare has been around for generations when it comes to the pharmaceutical industry and the insurance industry. But this same level of distrust and resentment towards hospitals and caregivers is really new. So we have to have a radar for that, and it really has to inform our decision making, how we navigate forward with those in our care. And so much of this is a byproduct of things that are out of our control. There's systemic issues that are play that are creating this perfect storm in the current state. We can't control that, but we own how we respond to it, and we should navigate in a manner that prioritizes our safety and protection and being supportive of our patients and their family members. That doesn't necessarily reflect the current state of things at most healthcare institutions. I think, to no fault to anybody's own, I think we do this pretty unconsciously and unaware that we tend as human beings just to apply a reasonable person standard to everybody that's in our care, including the most unreasonable people among us. My favorite quote from The Gift of Fear, a great, great book, the only book that I keep on my desk. Believing that others would react as we would is the single most dangerous myth of intervention. And I circled that and I highlighted it. It really spoke to me, especially, reflecting back on my early career. I had a tendency to project whatever I would do in a certain situation on the individual in our care. And the results were often disastrous. And we do that unconsciously. What we can relate to best is our own experiences, right? So we tend to, without knowing it, we will project what a reasonable person like us would do to somebody who might be in the throes of substance use disorder or acutely intoxicated with alcohol, or might be suffering with undertreated or totally untreated mental illness, or who just experienced the loss of a loved one or a job, in those moments. So I think that has been a little bit disastrous. I think it's okay as human beings for us to understand our judgment and our biases. And so often, there's a tendency to judge those in the throes of substance use disorder. Um, Behavioral health discrimination is certainly real. People with criminal past are often discriminated against in healthcare environments, and we understand why, but we have to really be intentional about understanding that and doing better, and living up to our values as caregivers, because otherwise we really create an adversarial relationships with folks who might have a propensity towards violence towards us. And I think agitation is often a symptom, particularly for those who are suffering with mental illness. And we don't get angry when the respiratory illness patient starts coughing. So if a person who's really struggling with their condition is agitated or disrespectful, I think the way we navigate those moments as professionals ought to be similar. We do things from my vantage point that are really relationship damaging in healthcare that often lead to preventable acts of violence. For example, I spent a lot of time working with folks about cell phones in the behavioral health patient. Very often, in most hospital emergency departments, if you're a behavioral health patient, you're given this up. And so often, otherwise cooperative patients are now fist fighting with the caregivers over the removal of the phone. And I think there are many pathways to giving that patient one chance. Because let's face it, this is like part of the human body for us all now. If I said everybody on this webinar, you can't use your phone for the duration of the hour, there'd be nobody on the call. Same thing with our behavioral health patients. So if you can create a pathway to leverage that, incentivize good decision making to get one chance with your phone, yeah, sure, take the case off. That's a requirement, for our patients. Sometimes there's drugs or weapons stowed in that case. We have to be mindful of that. But the more we can treat these folks like human beings, we don't take phones away from our medical patients for a reason. And I've always advocated for a one chance policy, meaning, you use it safely and appropriately. You start audio and video recording or live streaming. We take it, you're not getting it back to the time of transfer or discharge. So there's thoughtful ways about doing this. And that's real workplace violence prevention from my perspective. Organizations that have instituted initiatives like that after they've seen restraint after restraint after restraint and injury to caregivers after injury to caregivers over cell phones, maybe you take a different stance on that and see if that actually reduces your restraints and your assaults with injuries. And then slapping labels on people like junkie or drunk or frequent flyer and how relationship damaging that can be. And I've interviewed patients after terrible acts of violence towards caregivers, and they've pointed to those labels that were slapped on them, that they were dehumanized by the people who were supposed to be caring for them, and then they ended up acting violently towards their caregivers. Don't get me wrong, no caregiver deserves to be harmed ever under any circumstances, but from these patients' vantage points, that's what pushed them down a pathway to physical violence was overhearing the staff call them a frequent flyer or a drunk. So this battle of when everything's important, what's important and what's most important is what I'm going to focus our time on today. And as caregivers, we're all risk managers at some level. We really have to identify what's most important to focus on. I call those our foundations, and everything else is just an element. So in the world I live in, we have to be prepared for everything. Some things are incredibly unlikely to occur, and other things are occurring with regularity. I'd call those crisis type of situations. So those are what we focus on first and everything else. Yes, we have to come up with plans, but there's only so much time in a day and only so much pie that can be carved out. So how we get to that initial risk level is likelihood and severity. But then once we've identified our initial risk level, what can we actually do about it? How can we mitigate and prevent relative to the probability and the harm that does occur from that particular incident or situation? And then we really land on what we can actually do from a prevention and mitigation perspective. So how do we prioritize when everything's important, but we have to determine what's most important? From my vantage point for the past 10 years in healthcare, these have been the top priorities for security and for workplace violence prevention. None of these are on my top 10 list as a practitioner with 25 years experience. These are very well marketed right now to senior leaders. I think rural health is largely immune to this just because what it takes to stand up weapons detection, the equipment, and to operationalize it with people is usually cost prohibitive for rural environments. But I'll talk a little bit more about why these things matter and they're important, why they're not to me foundations. To me, these are my foundations because our data has indicated year over year for the past 25 years that I've been in this that the harm is happening at the bedside here. So bedside safety and protection, training folks on disengaging to keep themselves safe. The best way to keep yourself safe, don't be where the threat is. That's not intuitive for caregivers. They rush into medical emergencies all the time. And then population-specific de-escalation. So if somebody's getting re-agitated, how can I bring that tension down and keep them and myself safe? Then administrative and engineering controls. What can we do from an environmental design and systems approach to try to protect our caregivers, and what type of policies and procedures and programs can we implement that are focused on violence prevention and ultimately professionalizing healthcare security? And I know many or probably most rural hospitals can't afford to actually have uniformed security personnel in their building. And I have some thoughts on that. So let's start by elements. I always feel like I have to prove this. This might make logical sense to the folks on this type of call, but in many other environments, kind of the haves of healthcare, the folks that have money to spend, I spend a lot of time making sure that I try to make a proof of why these are just elements. Really, anything that's a low probability event. So you're more likely to be struck by lightning twice than be involved in an active shooter situation in a healthcare facility. It's actually the place in society that's had the fewest active shooter incidents of any place. So it's happened. And when it does happen, I can't think of anything more impactful to an organization, but the probability is so incredibly low. So any low probability event to me is an element of your program. It's not a foundation, but so many workplace violence prevention programs across our country for many years now they're so rooted in active shooter. To me, that's preposterous. I know this is really important to a lot of our workers because they watch the news and they worry about those what ifs. So there's absolutely training and education we have to provide. But it does seem like we're experiencing a shift recently, and candidly, because so many caregivers have been absolutely traumatized through these dynamic simulations they've been put through these full-scale active shooter drills when they have never had any type of awareness or department level tabletop type of training on the subject. They're just pushed forward into this stuff for events that are such low probability. So I fly on airplanes all the time. It's the safest form of travel. There's incredibly low probability of a bad thing happening. But if the plane goes down, it's going to be the worst possible outcome and impact and severity. But that's a dice that most of us role. So we do need to make sure we're be irresponsible if we're not doing anything around extreme violence and weapons encounters and active shooter. But awareness level training, department level training, I've done so many thousands of hours of trainings myself with our workforce over the years. But we really focus on just your personal decision making, your options in a worst case type of scenario. And also really that concept of normalcy bias, our brains have a funny way of tricking us to minimizing the danger we might be in an extreme situation that's never occurred to us over the course of our lives. And, every second's going to count in those moments. And ultimately the run, hide, fight. Well, what does the fight mean? And when we go into attack mode, how do we disrupt the OODA loop? That's the stuff we really spend an hour talking about across the organization. And then we also have department level because we found that wasn't enough for our workforce. We can talk concept, run, hide, fight, but let's bring it back to the department, the place where folks work, and run through a scenario. It takes all of 10 minutes usually to think about run, hide, fight critically right in the place that you work, and then document that training and share it with others and learn from it. So I'm all for this. I'm an absolute total opponent to full-scale exercises and simulation drills because ultimately don't give anybody a false sense of security of being in a gunfight. Sometimes people run through this, they do some fight tactics, they forget everything they learned within 2 weeks. I don't want them to have a false sense of security if they're in a situation where someone has a firearm and they're looking to do harm. I like to say, you know, run, hide until you run, fight until you can run. So run. Best way to keep yourself safe. Don't be where the threat is. Never ever try to attack an attacker unless that's your only resort. They're directly confronting you and you have no option to run or escape. So weapons detection again is really the focal point, probably not so much for rural hospitals, but I'm sure it does come up. And the only place in our lives where we actually experience effective weapons detections at the airport. It really takes that level of equipment and infrastructure and personnel that operationalizes it to do this the right way. Everything else is largely, in my opinion, security theater. It might do a job at creating perceptions, but it's not truly accomplishing its aim. I think if you have one person that's unarmed, that's wanding, somebody that security officers an incredible risk of harm themselves if they're doing it solo, but a lot goes into this to doing it thoughtfully and doing it safely. And so many organizations, they might just do it 12 hours a day in their emergency department. Well, what about all the other entry points? A true bad actor is going to do enough research and planning to know how to enter the facility with their firearm if they intend to do harm. They're not going to come during those 12 hours or try to go through that one door. And other places that, again, I'm not trying to be too much of a critic. You got to start somewhere. If you're going to implement a program, you decided it's a foundation, sometimes starting with your emergency department, then building your program out from there. It makes logical sense to me. You ought to have really good visitor management system in place and access control systems in place. Then the logical next step to me is weapons detection. But I've been to places that there's no semblance of visitor management system or access control systems. They just go right to weapons detection. That doesn't make much logical sense to me. My money back guarantee I give every audience I speak to is I promise you this is I'm as certain as death and taxes on this one. Death, taxes, and I can get into your hospital with a fully loaded firearm. And there's nothing special about me. Anybody on this call could do it with a little bit of research and planning. When I've said that in front of groups of people that do weapons detection, I always meet with them privately and I say, you tell me how I would get in. And they give me a list of a dozen different ways. They already know that it can be done. And I'm sure a lot of you are living in constitutional carry states where people are lawfully carrying these firearms. And then you can have a no weapons policy, but if they enter with their weapon, it's still lawful for them to be carry. You have the right, besides in an emergency department setting, to deny them from their appointment or their procedure. EMTALA law would still come into play in the emergency department. Often, a medical exam screening could be done with somebody who's carrying a firearm with enough people to make sure that the care team is safe. But be thoughtful about these types of things. And, if you build it, they will come. And a lot of these constitutional carry states, they stand up these systems that a lot of encounters then over the firearm. And if you have lockers out front, that could be a pretty good way of going about it. But ultimately, I think these are really low probability events. Sometimes it does make good sense to focus on areas like emergency department and any type of inpatient behavioral health type of care. But if you build it, they will come. You need to make sure you have really good process. People know how to operate this equipment. They have good training. They work together as a team. They know how to navigate the what if situations because the weapons will come in. Weapons have been entering healthcare facilities since hospitals first opened. So oftentimes the people who are carrying don't have any intention to utilize them for harm. So there's so much that factors in here, but it has taken an awful lot of the conversation nationally right now. Um, Element of the program at best, in my opinion, just based upon data and probability, but I don't discount the impact of when a weapon situation does occur. It can tear any organization down and it's going to be hard to recover from. But what's of greater probability is improvised weapons. And how much training do our healthcare workers have on this? Usually minimal or none. There are things we often do with checklists to try to make an environment of care as safe as possible and remove certain things that could be weaponized or used for self-harm. That's typically the best we can do. But, I've lived through many, many encounters where caregivers have been attacked with improvised weapons over the course of my career. So we've tried to empower them with options and some training, how to navigate these moments, try to, safeguard the environment the best you can. But what if you are attacked? Because these type of improvised weapons can do significant harm, and there are far greater probability of being utilized in your healthcare workplace than any firearm. And without question, the greatest probability is attacks by hands and feet and mouths. Chances are, if you've had a caregiver in your organization that's been battered at the bedside out of work for a week, a month, or months, or perhaps they never return to their chosen profession, chances are pretty good they were subjected to one of these types of attacks. The average U.S. healthcare worker has far more training on active shooter response than they do bedside protection from hands and feet. To me, if we really want to get serious about violence prevention, this should be a real priority for us. So much of the data indicates that this is bedside reactionary patient-generated violence, but almost all bedside caregivers I've met the past 25 years have zero training on bedside protection, but something can and should be done about it because it's of the greatest probability. You can probably see from the top left there what I think about zero tolerance. This is all rooted in the best intentions. I championed this stuff 20 years ago. I plastered these signs and symbols all over my hospitals. Um, but I've always been looking at the data. And when I did, those data trends of volume and severity continued to climb up. Ultimately, how effective are signs? The population we're trying to reach probably not going to read the sign. If they do, they might see this as a test. They might see this as a line in the sand that they're willing to jump over. And ultimately, these lists of thou shall nots on the screen here are behaviors that occur with frequency in most hospitals on a daily basis. And how empowered are we to have zero tolerance, to have people prosecuted? The justice system's out of our control here. So at the end of the day, if any of you, I'm sure many of you that call have children, so you know better than anybody if you've got kids in your life that if you say but you don't do, you lose all credibility. So oftentimes this messaging loses all credibility for us with the community we serve, but especially loses all credibility for us for our workforce because systemic issues outside of our control, we can't follow through with the zero tolerance and the termination from practice and the prosecution very often. But at the end of the day, again, how effective is this sign going to be on your commute home today? So signs are a bit overrated. There's a place for them. Signs should be public facing and reflect our expectations and values, but they really don't prevent much violence. Code of conduct for patients and visitors has really gained some traction the past couple of years. There's some value to having this in writing as a resource you can produce after somebody's had bad behavior. Sometimes it really does help. Never present this to somebody that's acutely in crisis. They're going to tear it up and throw it right in your face. But, if it's an ambulatory type of patient that's presented some behaviors of concern, sitting down, a provider and other leaders and really going over, this is what you can expect from us and this is what we require from you to move forward. There is some value to this, but I know of a real high profile organization around here that has over 2 million patients, and they were so proud of standing up their code of conduct. This was going to be the real solution to preventing violence for their organization that they messaged this out to all 2 million patients. And they ended up having their call center ring off the hook of people calling and pretty much saying, why the hell did I get this? What did I do? So that was an unintended consequence of doing this. At the end of the day, what's happening to their volume and severity of violence? you know, Again, I get it. I have one. I understand this, but it's really not a great violence prevention tool. It just tries to reinforce our messaging. It's usually better to have a difficult conversation with the patient or their family member and use this just to have something in writing here. But I like to say for every complex problem, there's a simple solution that's totally ineffective. And so often when people see this, they really are perplexed by it, and it becomes almost kind of an adversarial thing. Some alternatives, though, I said having a public-facing message that reflects our expectations and values is important. Over on the left side is the signage that my workplace violence prevention committee had came up with. It doesn't prevent any violence, but it does, give a message of what our expectations and our values are as a workforce, and I think that matters. And then often coming up with behavioral agreements with patients, and sometimes the most difficult situations is visitation. So there is a place for that agreement or that contract, and I've certainly created a lot of those over the years. But that's for ambulatory setting. That is outpatient. That is not for somebody acutely in crisis. It will have no effect for them. Another hot topic has been legislation. The federal government has picked this up, many times over the years, and right now a lot of states are enacting legislation with punitive penalties for those who harm caregivers, and I'm all for that. I lobby for that as well, but I don't think it's going to prevent much violence. If it does prevent one act of violence, it was worth it. If it holds one individual accountable for harming a caregiver, then it's worth it. So I'm going to continue lobby, but I by no means do I think this is any sort of solution to our violence problem in healthcare because we often overlook that, all these statutes have stipulations that the individual had to knowingly and willingly commit the act of harm. That's a high standard. And who are the top three patient populations who are assaulting and injuring more caregivers than any other? Here they are. The geriatric delirium dementia population not going to be charged with or convicted of a felony, nor should they be. Not going to pay any penalties and fines. Obviously to no fault of their own, they do harm. It's really a byproduct of their condition, and we don't judge them for it. But that's a big part of it all. And then number two on the list is pediatric behavioral health patients, not going to be charged with or convicted of a felony or pay any fine. And then the third big population is acutely psychotic adults. When you could convince me that they should be legally culpable for their actions, but if you've ever watched an episode of Law and Order, before you understand we have generations of case law and legal precedent for folks not being legally culpable for those actions due to their mental illness. And that is so much of the pie of folks that are harming caregivers. So we do need to take that into account when we really start to steer towards where the idea that we're going to legislate ourselves out of this epidemic of violence in healthcare. I just do not believe that'll be the case. And ultimately, we can be really thoughtful about is punishment at the end of the day a real deterrent? And we take a look at the airlines during COVID times and that skyrocketing uptick of unruly passengers and terrible behavioral issues that were occurring in the airports and on the flights themselves. So a lot of information is out there. But towards the bottom of the screen, it's very interesting to me that once the mask mandates were dropped, everything normalized relative to the behaviors. There's always going to be behaviors in airports and on airlines because a lot of people consume alcohol, to really overcome their fear and anxiety at the airport. And that typically will lead to behavior, as anybody in healthcare knows quite well. But everything really normalized to pre-pandemic type of statistics once the masks were dropped. So that's the best. That's top of the chain here. Whenever you can eliminate whatever the cause of the issues is, and they effectively did. And ultimately, of course, there is federalized legal penalties for acts towards airline workers, but it didn't deter him. Again, there are certainly folks that are altered, who are under the influence, who lash out. They are not navigating consequence the way that you and I do when they lash out violently. And I came across this cool quote. If a violent crime is to be curbed, it is only the intended victim who can do it. The felon does not fear the police, and he fears neither judge nor jury. That really reflects my own personal experience. Jeff Cooper said that, and I borrowed it from Mel Cortez in the work that she does. So that's a lot about elements. So, what are the true foundations? To me, it really starts with training and education, and we have to constantly renew and refresh on our training and education. They are perishable skills. I know that. But I'll tell you what, Archilochus said this in about 640 BC, and doesn't it still reign supreme today? I've certainly lived through that many times in the different critical incidents I've been involved with over the years that, training's where it's at. We expect violence here, but it could often be avoided and mitigated through preparation, and the best way we can do that. But training, what does that mean? What should our real focuses for our training be? To me, it starts with bedside protection and population-specific de-escalation. Here's a bit about what bedside protection means to us. And I've consistently been able to drop assaults and injuries on nursing staff over 75% at the hospitals I've worked with over the years just by implementing a bedside protection training program that focuses on all of these things. Again, the average caregiver today that's going to be brutally battered is probably a very well-educated, brilliant, talented person that is leaning over a bedside rail like this to administer care. To a security person, this is just presenting targets. And the patients that are best at acquiring targets are those with dementia, those with behavioral health conditions, those who are acutely intoxicated. Okay, so I've done an awful lot of work with caregivers over the years about really managing your position and your posture when you're that close at the bedside. The opportunity for harm is ever present for bedside caregivers, so they have to be up close and personal for all episodes of bedside care. So instead of presenting targets, can we move in on an angle? Can we have really good balance? Can we really just kind of organically bring our hands and arms up as we move closer to provide care? And can we be vital line protected, nose to belly button, bladed away? And most of all, be a team at the bedside if there's a patient we're concerned about, and especially if this is a patient that has demonstrated past risk behaviors or violence. So if we have a good, balanced protection stance. And most of all, if we condition ourselves to be prepared, if the patient starts hitting and grabbing, walk, more importantly, move. The best way to keep yourself safe, don't be where the threat is. Get back to a 6 foot line or what I call spitting distance away from the patient. And that's going to be the best thing you can do to maintain your personal safety until you can activate more help. But healthcare workers are not wired that way when we rush in. So it's very often caregivers are right at the bedside, really open, leaning in to administer care. And once their patient starts grabbing and hitting, everybody rushes in. They're trying to grab something, effectively controlling nothing. And it's target practice. And a caregiver is getting brutally battered. And they're hanging in there as everybody tries to gain control, very often disengaging, getting away from the bedside. And I'm one from my own personal experience in my early career, I must have been spit in the face well over 100 times. And very often patients are biting and spitting, and we're just trying to gain and maintain control. And it's target practice. It took me years to realize, the weapon's the spit, the target's me. I can't control the weapon, but I own the target. So if we got everybody back and disengaged to a 6 foot line, never once did a patient in a supine position jump out of bed and chase us down the hall to try to spit at us. You know, but these are not intuitive to healthcare workers. These require practice and training. And very often, people are harmed during the application of restraints or even the removal of restraints. We want to be a team. We want to be really strategic how we do this. And it really takes practice, really focusing on how we can physically control aggressive behavior, controlling the arms as weapons, controlling the legs as weapons, controlling the head and mouth, but most of all, having that disengage mindset. Block, more importantly, move away if somebody's trying to hit and grab. And population specific de-escalation to me is where it's at. And just like partnered practice is so important for bedside protection, it's the same. Role plays are really, really helpful. Trying to limit set and really coming up with some population specific communication strategies because these populations vary considerably on how you want to approach and how you want to best communicate. And the more we educate our workforce to develop those strategies and approaches and skills, particularly when it comes to cultural competency as well, it really leads to safer and better outcomes when it's a real situation with patients in our care. This is an hour course I do with my workforce. It's incredibly well received and required for our entire nursing staff because they're always navigating encounters with emotionally confrontational people. And I love the old verbal judo 5 universal truths there. I think those are really the foundation of de-escalation I've taught over the years. Engineering controls are really super important. What are we doing with our physical environment of care to try to protect our caregivers and keep our patients safe? Plug to the IHSS, they just put out their fourth edition of the security design guidelines for healthcare facilities, and I've seen this in rural hospitals I've connected with that they have this and they go to this whenever they're doing renovation or new construction. They go to the guides and they're really intentional about investing when it comes to these protective measures here, having barriers in place that protect caregivers when they're most vulnerable. Some of these horror stories are caregivers distracted by charting and all of a sudden enacting outpatient approaches from right behind them and does harm. So what barriers can be put in place to protect our caregivers when they might be vulnerable and distracted? And, electronic access control, I think, is really important, controlling who's coming into certain areas. Video is great. I love public facing monitors. We have a retail pharmacy right outside where I sit. And when I arrived at this organization, we put some two big public facing monitors right at the retail pharmacy, which has been in place for retail pharmacies for many years because they're a real proven deterrent factor. So I like them in emergency department lobbies. I like them at main entrances of people coming in and immediately identifying that they are on recorded surveillance as a deterrent. Panic alarms and duress alarms, I think, have some importance, but so often the harm's already done before anybody pushes the button. So they're not a solve all, but they should be something. It's really important to activate immediate response. But in the healthcare environment, who is that going to be? Is it local law enforcement, the sheriff? What's the expected time frame that it's going to take for them to respond? And I've talked to some folks that said it could be 20 minutes, it could be 45 minutes. Heck, they might not even be coming. The local sheriff has the same staffing issues that the hospital does. There might only be one or two people on duty for a very large square mileage. So we oftentimes have to be very independent in healthcare and very especially in your rural health environments. So if you have any technology, who's it activating? You may not have in-house security personnel, so who gets that message and what's the anticipated response time? Integrating your systems are really important. You can often integrate your identification, your access control system with your camera system. I'm a big fan of license plate reading cameras that we've implemented where I work, which have really been helpful. But ultimately, in the care environments, what are you doing? Very often focused on patient safety can also really protect caregivers when we're taking these different type of measures with the equipment in our patient rooms and our processes of how we care for patients as well. In administrative controls, I'm a big proponent of visitor management, really having ownership of who's coming into your facility and having a screening process. That's sometimes perception building, just like weapons detection, but it does matter, I think, for the safety and security of your building. Uh, I don't have canines here, but it's certainly on the wish list. And I know a lot of healthcare organizations had good success with their canines, and those actually can be trained as weapons detection systems, and they're mobile. They probably do just as good a job as fixed equipment, and you could move them from point A to point B. Body-worn cameras is something that law enforcement's been doing for years, and more healthcare organizations have been doing, and there's been a deterrent value, and the research and the data indicates that. Threat assessment and threat management teams, this is an absolute must-have for every rural hospital environment, making sure you have a threat assessment and threat management process, that you're following up on anyone who threatens to harm members of your workforce, or maybe it's a past worker who's threatened the organization or an executive. That is a area that we're often behind in healthcare, but usually local law enforcement, colleges and universities have a mature threat assessment and threat management program, and IHSS is actually offering a great new course on that. What are you doing about lateral violence, incivility, and bullying? That's really something that we control more than anything else is the behavior of our workers here, and that's happening at your organization. So oftentimes it's easy to put the blinders on, but we got to be intentional about starting with us and what we do to promote that culture of safety and respect as a workforce. Then your intelligence programs, really, if you're capturing reporting data, what are you doing about it? Who's analyzing this and how is this informing your decision making? Are you doing heat mapping? Are you finding out where we're seeing what's the epicenter for our incidents? Who are the patient populations who are causing a lot of this harm? Are you really measuring that, and how does that inform decision making? Are you doing any type of evidence-based violence assessment in your electronic medical record or things like that? Are you putting in flags and alert systems to notify caregivers of past incidents of violence? Are you doing it in a manner that is very objective in nature and is not biased or discriminatory if you do place flags on that? But, at the end of the day, I believe in flags, but the best predictor of the future is the past. And if someone has past incidents of violence, at the very least, we should be notified and aware of that. Every encounter is a new encounter, but I'm more heightened from when it comes to my own personal safety if I know there's been a past incidence of violence, and I'm probably more likely to go in as a team, standardizing plans of care for your patients that have been causing the most harm at your organization, being consistent, being a team. Behavioral emergency response teams have really started to pick up momentum. I'm a firm believer in those. Those are often consult services that come in that can, some of these patients will be here for an extended period of time. What can we do? How can we create that care plan with the right stakeholders involved that are really experienced and trained? We talked earlier about behavioral agreements and those difficult conversations. I've seen those make a tangible difference. Because from a threat assessment perspective, I don't want to have a doctor terminate a patient from practice. Very often, that's what's called a last straw event. So understand what a last straw event is and avoid creating last straw events. So sometimes it's better to have a really hard conversation, but keep that person in our care and have an agreement of, okay, we're resetting. These are the expectations moving forward. We're going to put that bad stuff in the past. Forward, forward, forward. I've seen a great outcome. And doctors who at first wanted to terminate those patients and probably would have lived the rest of their lifetime looking over their shoulder for those individuals. Just let's face it, some folks are hardwired differently than us. They're aggressive by nature. They're injustice collectors. They perseverate on individuals to blame for bad things that have happened in their lives. So sometimes continuing care, but coming to an agreement and not backing away from a difficult conversation makes all the difference. And lastly, professionalizing public safety and security. Again, it's not lost on me the overwhelming majority of rural hospitals do not have uniformed security personnel on duty. I would hope moving forward that that changes because ultimately, from my perspective, you know, an episode of a violent person trying to harm a caregiver is the same in a small rural hospital as it is in a large academic medical center. Um, in that room, that violent person trying to do harm, it is no different. What varies is the response capability. And I know it happens at a different scale. A hospital like mine, we're going to see it at a much larger scale than a rural hospital. But when it happens, is there anybody that can be called upon to come in and be that front line, to be that early intervention go-to person to try to do that de-escalation work. And ultimately, if you do have to go hands-on, if the provider orders restraints, who's gaining, maintaining physical control? That's so often when our nurses get battered and injured, where public safety professionals and typically have an awful lot more training. So I hope this is the future. Heck, I'd love to see our government funding put to good use. This is something I think that really this country should invest in for all hospitals is the capability of standing up security programs. So there's ways it can be done and has been done, but it's not lost on me that, when it comes to positions, how careful rural hospitals have to be when they manage positions. So sometimes you're going to have to borrow and replace other positions to create any type of public safety department. So this is what I've tried to cover in our hour together here. Again, hopefully, it was time well spent. I know that the Safely Managing Agitation and Aggression webinar should be available to you as well for those who weren't able to make last time. That's my contact information below. If you have any specific questions or feedback for me, I'd welcome you to shoot me an email. I'll definitely respond to you. And talking about violence can be pretty intense. So I always like to wrap it up with a picture of my four cats here to bring the energy to positive. So I'll go ahead and I'll stop my share there. And I do think we have a few minutes of time left. Josh?
Yeah, thank you very much, Brendan. That was very informative, and I love the pictures of the cats at the end. We do have a couple of questions in the chat, so hopefully we can get to all of them. So the first question is, what about the safety care training that schools get? And really, I think that's focusing on preventing and managing challenging student behavior. So is there a training that correlates to that for folks in a healthcare setting?
Sure, and I think a lot of the big vendors that do workplace violence prevention training, and education, and healthcare, often their biggest client is K through 12 education. It is often kind of parallel skill sets of how your strategy and your approach of how you try to effectively de-escalate person, and they have to do restraints and talk about high liability, having to go hands-on and restraining students, the last resort. And there's a lot of parallels to healthcare, so I do think there's incredible value for our workforce in getting that level of training. And I think it is very parallel to what those working in education are required. Oftentimes, that's a hard condition of employment for teachers and educators, where sometimes in healthcare we lag a little bit behind about making time. And it's not lost to me. It's so hard to get caregivers away from their day job and the bedside to be in a classroom. I get that, but we need to be intentional about it. I think these skills are so incredibly important and will be utilized daily by the workforce.
Excellent. We have another question here regarding zero tolerance. What options does a facility have if they say they have zero tolerance but cannot immediately discharge an aggressive patient? And then they go on to say, agree that zero tolerance sounds important, but without teeth to implement, the facility becomes impotent.
Yeah, like I said before, it bears repeating. If you say but you don't do, you lose all credibility, not only with the people that you're trying to impact their behavior, but especially your workers. So to me, zero tolerance was rooted in the best intentions. I meant it. I championed this stuff 20 years ago, but I looked at my data. It had no impact. It had an adversarial impact, if anything. But what do we stand on? When I tore down the zero tolerance signs where I work, we came up with a new standard. What it is every reported event will be thoroughly reviewed and individually addressed using state-of-the-science, data-driven best practice. I can live up to that. Us as an organization, we can live up to that. We cannot live up to zero tolerance. Okay, EMTALA comes to mind to that point. We are responsible for this person's emergency care even after they've acted out violently. We cannot send them out of our facility. So again, I can't live up to zero tolerance, but I can live up to every reported event will be thoroughly reviewed and individually addressed using state of the science, data-driven best practices. I've said that a few times before here, but that's what we replace zero tolerance with where I work.
Thank you, Brandon. Then we have another question here. It was actually asked twice, and it is, do you recommend any training programs for responding to patient-initiated violence? And also the one individual that put that question in made a comment saying, I found some of the standard ones to be not super effective or practical in real life scenarios.
Yeah, that's a good point. There are many programs out there. I think it comes down to the quality of the certified instructor. So often, if you're investing in a member of your workforce to become a certified instructor, it has to be the right person. They really need to be engaged and put in the time and energy to learn the material to the level to teach it. But where most of these programs have fallen behind is so much of the encounters in education are standing. So they're kind of like escort based or, type of skills that are not what we see as a supine patient laying back in bed is so often who we're encountering and going hands-on. So some of these programs are starting to catch up with not having it all standing type of intervention and escort based. They're doing more and more of bedside control and restraint in their curriculum. I don't want to plug any individual program because so many of them are great supporters of the IHSS. But if you email me offline, I will respond and I'll name names, so to speak, about who I think are the best organizations out there right now for training a healthcare specific workforce and what we do.
Very helpful. Thank you, Brendan, for that insight. And I think that could be a great resource. We have 1 minute. I do have one more question and then we'll wrap it up here. This is just a question on my own accord that I wanted to bring up because I know we do have healthcare leaders on this call, on this webinar right now. So, in your experience, how does leadership presence or absence affect staff morale and response after a workplace violence event?
Thank you, Josh. I think it makes all the difference. And I think our workforce knows we're not perfect. We can't prevent everything from happening, but we show up in a really meaningful way after an act of violence. It really speaks volumes to our workers. Where I work, anytime there's a completed physical assault, I let the functional vice president that oversees that service know about it. And I'll tell you, Josh, 100% of the time they intentionally follow up. They make sure the caregiver that was harmed feels supported and has the opportunity to give any safety recommendations for moving forward. And they'll always connect with their local nurse manager and other leaders to make sure we're taking measures to try to prevent this from reoccurring. So yeah, leadership has such a big ownership stake.
Excellent. Thank you so much, Brendan. We appreciate everyone's time. We see a lot of great just comments coming through the chat. Great job, Brendan. And Lorena will send a follow-up survey just to get that information along with the recordings of the webinars series. So thanks again, everyone, and take care.
Thank you. Be safe, everyone.